Hello, good evening. This is Dr. Radialis from the Georgia office. Um, so tonight I don't have a particular subject, but I will be discussing some cases and answering questions as they start popping. So today I want to talk about a few of the cases that I thought were very interesting this week. I will talk about a discussion I had yesterday with a dear patient slash friend, if you want to call it that way. She is 45 years old. Um, to her blessing, her AMH is 1.5. So she is working on getting IVF with her eggs. This is her third cycle with IVF. She did 2 cycles at her local clinic that were somewhat successful. She decided to do PGT testing on the embryos on the first 2 IVFs. And the first cycle, all the embryos were abnormal. Second cycle, she had one normal embryo. Um, and she was producing about 4 to 5 eggs per cycle. On this particular occasion, she did priming. She did a mini IVF. This is the cycle that she just did with us. She got 11 eggs. That was fantastic. 8 fertilized. She wanted to test her embryos again, so she pushed them to blast and got 4 blasts to biopsy. And yesterday, the discussion that we had was they were all abnormal. So this is something that I see every day, day in and day out. And that's why I kind of picked her case to go over on our conversation tonight. Um, it is true that through this process, we're always trying to control the outcome to some degree, and at the same time trying to control some of the issues that got us to a fertility journey, right? Unfortunately, you can't control it all. And once you're like past 40, past 42, even if you have a good AMH, um, it's going to be really hard to guarantee a genetically normal embryo. And like I was talking to her yesterday, a um, genetically normal embryo does not guarantee a pregnancy either. So the discussion I had with her is what to do next, because now her 4 blasts from this cycle were abnormal, and she has one normal from her previous IVF cycle. And the question was keep going or transfer the one normal that she has. But now that's the only normal that she's had in 3 IVF cycles that produced about 20 embryos. Um, so this is what I recommended her. I recommended if you're going to have a leap of faith, then have a leap of faith. You're trying to have your own eggs at 45, and with eggs embryos after 40, they do better on fresh transfers. So what I was telling her is that she had 8 um, 8 embryos on day 3 that looked good and had a good appearance. So the beauty contest that Dr. Keels talks about. And I had recommended for her to transfer on day 3 and freeze on day 3. Why? Because sometimes the eggs past 40, they're not necessarily abnormal when we start the process, but they're more frail for sure. So when you push them, to blast, sometimes there could be some degradation, or you could lose what were normally genetic embryos, and in the process, just because they were outside of the body. So older eggs do better inside the body. And that's where on our last discussions, I was talking about hyperovulation 40 plus and how that increases chances of pregnancy and not so much multiple. Yes, you're going to have also more abnormal eggs that goes to the territory, but chances of having a the fear of having a baby with like severe deformities, it's actually not that much higher. What do I mean with this? Usually it's either going to be a biochemical or it's not going to attach at all. So a good compromise, because she was not so happy with my recommendation. So a good compromise that we came up with is, you are making a lot of eggs. We can do things to try to optimize your eggs. We already did 2 PRPs. She's doing NED IV infusions. She is on glandular therapy and supplements. She is doing keto. She did Omnitrope. We are trying low dose ACG priming. She is on LDN. So we're trying to optimize the quality of her eggs. So a good compromise is, let's put day 3, the best looking day 3, on a fresh transfer. And then if you want to push the other ones, then go ahead and do so. So I like recommending fresh transfers on my older ladies or decreased ovarian reserve ladies, because sometimes that's where the miracles happen. It's an embryo that was not frozen. It's an embryo. It's an embryo that went from your body to the lab for 3 days and back into your body. So that's where we see that women past 40, they do better with fresh. So that's what I recommended for her, and she is going to discuss that with her husband, because yeah, he was not, he was feeling that it might be time to, stop the journey. So I know that's also a challenge that you guys have all the time, when you have one partner that is ready to quit and the other one is not, or one partner that's ready to do donor egg and the other one is not. So all of those challenges that we share in this process, you know, it's worth discussing, because there might be somebody out there that has a similar scenario. Okay. All right. So let's see what you have here. What about transfer a normal and an abnormal? Yes, you can definitely transfer an abnormal and a normal. We are very relaxed with that at CNY. Dr. Kills is not a big fan of testing embryos. I'm not either. That scenario that I just described, I see it so much, is heartbreaking. Even in younger women, 38, 37, that it's like they want to guarantee that the pregnancy is going to be perfect or whatever. And then they do all the testing. Maybe they get, out of the 10 embryos, if they're younger, they'll get 3, 4 normals, and then they transfer and it doesn't work. And they're back to the question, why didn't it work? It was a normal embryo. Well, a normal embryo does not guarantee a pregnancy. There's debate about whether the biopsy itself might mess up the embryos and its capacity to implant. So unless you have a very, very specific scenario, in my book, testing should be one, if you feel very adamant about the sex of the baby, meaning you have 3 boys, you want a girl, you have 3 girls, you want a boy, you don't want to keep, living up to nature. Okay, I get it. And then the second scenario is, you have a lethal genetic issue, or you've had a child with a genetic issue, and you want to make sure that your child does not inherit that gene. Absolutely, I think that's a no-brainer. But just to make sure that it's okay, then do the genetic testing on yourself and your partner to make sure you're not carriers. That's a lot cheaper and a lot less invasive, and let the rest to God. That's why I've said this like 100 times. IVF is 50% chance of success across the nation, and it's been around for over 50 years, and it's still at 50%. Why? There's a lot of factors that can be controlled, and there is the unknown, the vine, the field, life source, that will finally determine what's going to happen. And then there's like that spiritual component that I'm talking about, and the psychological component of the parents. All right. Okay. So yes, going back to Cindy and the normal and the abnormal, yes, you can. I had a patient transfer 3 mosaics, and she had a beautiful baby girl. What can happen at 38? Is it better to transfer freeze on day 3? Every case is different. We would have to see what is your ovarian reserve, how did your body respond and behave during treatment, because we're not treating numbers, we're treating people. And sometimes your body will behave like you're older, sometimes it'll behave like you're younger. So it'll have to see what happened, what has happened with the transfers, if there's any. And it's almost better that if you haven't done so good and your body is behaving like a low reserve body, even if your AMH is more than 1, to definitely do day 3. And if you did not have a big retrieval, if you had 5-6 eggs and you're a candidate for a fresh, definitely go for a fresh, unless you have an inflammatory process like adenomyosis or endometriosis, and that's a different scenario. TSH was 1.6 before egg retrieval. Now 3 weeks later, it is 3.9. Yes, what happens is that estrogen will inhibit the thyroid. And as you all know, we use piles and piles of estrogen, and that will mess up your thyroid. That does not mean that you're going to have thyroid issues for the rest of your life. But that's why it'll fluctuate like that, and that's why we're obsessed with checking it. We just want to make sure it's in the right range, and we compensate for whatever estrogenic effect we've been causing on your thyroid. Okay, my husband and I had a child 4 years ago, and now he has he has lost all of his sperm, and doctor can't figure out why. Absolutely, I see that all the time, Amanda. Even with COVID, I had a patient with a normal count, and this was a little heartbreaking. She has endometriosis. So far, we've been kind of saying it's more her than him. His sperm analysis was 50 million, normal motility, normal morphology. So he's been fine all along. They decided, because they had 2 biochemicals with the IVF, so we're kind of trying something different. So we hyperovulated her, did priming, PRP. I did a laparoscopy on her. She did absolutely fantastic. We were so excited. She had 5 beautiful follicles. So I was like, oh, she's getting pregnant. For sure she's getting pregnant. Her husband had COVID a month before. And he felt better, so he kind of forgot about it. He comes in for a fresh IUI. He had 5 million. I was trying to keep it in, but I was like, I had to gasp for air. And so things do change. Our bodies change. It happens in men and women. We see it all the time. I see people that come in and they are saying, oh, I had 3 babies in my younger years, no fertility problems. I just tied my tubes. Why do I even need to check? Because I know I don't have that issue. Our bodies change all the time. And next thing you know, their IVF is failing. Next thing you know, they had hit an endo that maybe when they were 25 and now they're 35, it didn't affect them because our bodies change. Our biological reserve gets diminished with age. So we have to figure out, Amanda, you're always welcome to reach out to me. What happened to your husband? Looking, kind of dig a little bit, medical history, any infections, does he have any chronic infections happening, any trauma, any hidden varicocele that might have gotten worse, okay, with the years because of the increased pressure in life and weightlifting and lifting in general. So just message me and we'll take a look at your case. Multiple miscarriages, even with BGT normal. Yep, Caitlin, that's what I'm saying. It's just, the testing sometimes doesn't add up much. Do you see increased success with the immune protocols? Huge. I prefer doing immune protocols than the PGT testing on the embryos. And at what point do you recommend a gestational carrier? Gestational carriers and donor eggs, it's something that you have to get there and be ready. I would exhaust all possibilities because you are getting pregnant. So it's more like trying to keep you pregnant and figuring out why you have miscarriages. So from laparoscopy, diet modification, supplements, PRP, huge. PRP is kind of immune to some degree, and playing with the immune protocols, potentially doing on ERA, even though you are getting pregnant, but potentially doing ERA, even the SIMA, are we dealing with a little bit of male factor and DNA fragmentation? Okay. Alrighty, so Miss Jamie is saying, yep, 38, one full ovary, so 6, 7 eggs, but only one normal. And it didn't attach. Yes, so Jamie, just, again, message me through Messenger. We'll take a look at your particular case. And just like I was saying about my IUI patient, sometimes you just have to spice it up. My IUI patient, she's been through 4 IVF cycles. Out of those IVFs, 2 were just terrible. The other 2 ended up with biochemicals. Her tubes are open, clean her endo and laparoscopy. She was on our Lisa for a while with the priming. And then we were doing hyperovulation on IUI. But unfortunately, like I was describing, her husband ended up with COVID and his semen analysis went haywire. So now we're working on him to try to get him to heal from the COVID, get better. So hopefully we can attempt the IUI again with both of them doing amazing. Okay. I only have 1 working ovary. Every follicle counts. Absolutely. What can I do to help my follicles grow more evenly? So you're having a lead follicle or 1 or 2 lead follicles. You want to manipulate that. I've had a lot of good success with long Lupron to kind of quiet down. So we get all of them to be the same size, and then start the injections on the Lupron. So instead of doing Cetrotide, you start Lupron, quiet the ovaries, start the injections, and then continue the Lupron as your Cetrotide. I have done that in the past. You can do it with priming, estrogen, progesterone, or birth control pills short term to try to quiet down the ovaries. And another trick also is to get a few ovulatory cycles, meaning doing letrozole, even if not necessarily to get pregnant. You could get pregnant, but doing letrozole cycles 1 or 2 ahead of time. That way you're going to stop recruiting the month before, and then you're going to have a better ovulatory cycle with all the hormones in the luteal phase, and then have a true withdrawal bleeding, etc., etc. When you transfer an abnormal that is successful, what tests are there to check if it's truly yeah, so let's say you transfer an abnormal genetically tested embryo, it becomes a pregnancy, and you're still a little worried about it. You can do genetic testing. Oh my God. It's called, there's several out there. LabCorp has its own. There's one called, it's not Horizon. I think it's Materna. Anyway, you can do blood work on the mother starting at 13 weeks to check the genetic composition on the baby. And of course, old-fashioned amniocentesis, you can do that as well. Do you recommend embryo testing with a balanced translocation, the husband? That would be one of the reasons to do testing if you want to avoid miscarriages. Now, I have had patients, it depends on how you feel about it. You can do testing to check for balanced translocation, and then that will avoid having the recurrent miscarriages for that. Or you can just deal with the recurrent miscarriages. The good thing about the balanced translocation, it's kind of a hit and miss, meaning if the baby does not have the balanced translocation, you're going to have an early miscarriage. But if you go past like heartbeat and 10, 12 weeks, that means that the baby inherited the balanced translocation, and you will probably make it to full term without any problem. So that's that. Is Menopur better than ACG? It is. There's several reasons behind it. Menopur has different variants of the LH component. It does have FSH. Menopur is human derived. It actually is derived from the urine of a large group of menopausal women. So the argument is that the little variants from different people put all together in one pool might work better for certain people. While SCG, even though it's the molecule is very similar to the LH and it works very similar in 99% of the cases, it is made in a lab. So it's just one molecule in one variant. I would say 70% of the time you can get away with ACG, the low dose ACG, without any problem, but the Menopur will work better on certain women, especially older women. It tends to work better as well. Can early menopause be reversed? So that's where my thing with PRP is. All the research on PRP and ovaries came about 15 years ago in Eastern Europe, and it was on injectable PRP and reversing early menopause and women getting pregnant in their late 40s after having the procedure on their own. Early menopause, depending how much into menopause you are, could be reversed. There's also some research on stem cell therapy. It is illegal in the United States, but it's out there. I've had patients that cross over to Mexico to get it done. I have mixed feelings about that one. I'm still kind of because it is foreign DNA and it could cause a kind of an immune reaction because you're injecting foreign DNA into your body. So I'm still kind of researching that a little more. I want to get more experience on it before I openly recommend it. So I have a group of women right now that are working on trying to reverse early menopause, and we're still working at it. So I will update you guys once we get more PRPs and more procedures on board. I'm planning to do IVF next week. I lost a baby at 13 weeks. He had Down syndrome. So that's why I decided to do IVF. Can I do a fresh transfer? So you can do a fresh transfer. And you can, okay, so you had a baby with Down syndrome. That means that he had an extra chromosome 21. It's a trisomy. And if that is the reason that you did IVF, then you have to do PGT testing. But having, again, normal PGT tested embryos do not guarantee a pregnancy, all right? And it'll depend on your ovarian reserve and so forth. What's the problem? That women that will have this type of scenario usually have low ovarian reserve. They're not going to make a lot of eggs to start with, and then you have to push those embryos to day 5 and beyond in order to be biopsied. So it's kind of like a hamster in the wheel. It never ends. So if you do decide to do a fresh, it is a leap of faith. Now, on the brighter side, because of how we do IVF and we try to optimize your eggs and your diet and the supplements, all of those things will improve the quality of your eggs. And so, you might have less chances of having a baby with Down syndrome just by that. But if you want to guarantee that the embryo you transfer does not have any trisomy or abnormalities in their DNA, you have to do PGT testing, understanding that you could end up empty-handed. You could end up doing IVF 5 times with 0 normal embryos, okay? And even if you do have normal embryos, that does not guarantee a successful pregnancy. Would you do laparoscopy if multiple small fibroids and a large cyst before stim? It depends on it depends on how many fibroids, where they are, and the size, okay? Because it's, let's say if you have one fibroid that's 2 centimeter in a corner and it's outside, everything is risk and benefits, then we might just leave it alone, because having a scar in the uterus, causes other issues or other potential issues. But if you have like 3 or 4 2-3 centimeter fibroids, then you're better off doing the myomectomy. Okay. I've had 2 egg retrievals, 10 eggs each time, only 1 fertilized, all others degenerated. Yes, so we need to see what's happening. We need to see how fast are you stimming. We need to see endo, PCOS, I agree. And I would have to look at your chart in particular, but definitely maybe do a laparoscopy and look for issues. Maybe stimming longer and lower dose might do you better. Dual trigger, make sure you do Lupron and ACG trigger. And priming, treat you, even though you got 10 eggs, treat you as a low reserve patient, and then actually kind of take a break, do the keto diet, or keto-ish, PRP, human growth hormone, or ACG, depending on the findings on laparoscopy. I don't really like putting people with endometriosis on Omnitrope. It tends to make it worse. What else? LDN, looking at immune protocols, even during the stim. All right. So just message me and we can take a look at your particular scenario. Do you recommend priming with contraceptives before IVF or low dose? All right. So when I talk about priming, it is really not hormone related. It is more LDN, Omnitrope, ACG, supplements, diet, PRP, IV, NAD. I try to avoid putting people on contraceptives. So if I have to, like say somebody comes in for a baseline and they have a crappy baseline, I might use low dose estrogen and progesterone first. The least amount of suppression, the better. The only exception would be PCOS patients. They actually do better suppressed with birth control pills before their IVF, but that's it. And we could do what I was saying before. Instead of suppressing, trying to do 1 or 2 cycles with letrozole first to try to get a normal ovulation with a normal rise in progesterone and a normal drop, to try to optimize your baseline without suppressing the ovary, but actually warming up the equipment. Okay. Last week baseline, had a cyst, and you placed in birth control pills. Will PRP be a great idea? Absolutely. It's not going, the PRP does not cause cysts. So it actually is going to help the ovaries work better. And if you do a high volume, it is actually going to be the whole system flush. So you're getting tubes flush, I just had 3 people today cancel their IVF treatments. Well, one canceled surgery for tomorrow because she's pregnant just with a PRP priming after 3 years of infertility. She called us and said, I can't have my surgery tomorrow. She was going to get a hysteroscopy because I'm pregnant. One of our nurses, gave us the great news that after her PRP, she's pregnant. So it does happen all the time. Double trigger. So there's studies that show that the double trigger improves the quality and maturity of the eggs. I do double trigger on everybody. Everybody gets Lupron and ACG. The difference would be the level of ACG. If I have somebody that's steaming really good and they have potentially 20 eggs, then I'll do a low dose ACG on that patient, meaning 2,500 up to maybe 5,000, and then do dosing eggs at the same time with them, just to make sure that they don't hyperstimulate or get really uncomfortable with the fluid in the belly. But sometimes when you don't you don't do that little extra push, you get a lot of eggs that are crappy, mature with very little fertilized. Same thing as there was another study that showed that taking using sting meds all the way to the trigger day also improves the quality of the eggs. Okay. All right, guys, time's up. Again, I'm Dr. Verdialis. You are welcome to reach out to me. And you can reach out either by finding me in Facebook, okay? Mary Bell Verdialis MD, that's kind of my official professional Facebook. If you, want to be my friend, you can do so. But this happened. I had a patient tell me that she was trying to message me, but it was not until she became my friend that her messages came through. I do try to be available for the patients as much as I can. I know that sometimes it's hard for you guys to communicate with us. Then there is the Atlanta phone number, the Atlanta office. It's 770-266-3930, which is 3930. That's the clinic side. The supplement store, which is kind of the back line. Rosemary is my assistant. 770-266-0933. And that's all for tonight. Have a blessed rest of your week, and I will see you guys in 2 weeks. Bye-bye.